Bismillah ar-Rahman ar-Rahim. Pulmonary thromboembolic disease treatment. First, risk stratification. The pulmonary embolism severity index is a validated score allowing stratification of immediate risk following pulmonary embolism, dividing patients into high risk and non-high risk groups, and clearly defines a low risk population suitable for outpatient management. The simplified pulmonary embolism severity index uses six variables and is non-inferior to the pulmonary embolism severity index in the predicting 30 days mortality. High risk, also known as massive hemodynamically unstable, there is pulmonary embolism shock or hypotension with positive biomarkers of right ventricle dysfunction. It is a life-threatening emergency and has mortality of more than 15%, usually caused by a very large clot burden, but can be seen with a smaller volume clot in those with poor cardiorespiratory reserve. Second, non-high risk pulmonary embolism, which can be stratified with the use of cardiac biomarkers of right ventricle dysfunction or myocardial injury into intermediate high risk submassive, in which one or more positive markers but no shock, and the mortality is 3 to 15% and requires in hospital management. And the low risk pulmonary embolism, when there is negative markers and mortality is below 1%. The echocardiographic features of right ventricle dysfunction occur in up to 25% of all patients with pulmonary embolism and are associated with a twofold increased risk of death. There is no agreed definition of the echo features of right ventricle dysfunction. On the CT pulmonary angiogram, flattening of the intraventricular septum and right ventricle over left ventricle ratio more than 0.9 suggests right ventricle strain correlating with echo findings and biomarkers. This is the pulmonary embolism severity index. As we see, the variables include the age, in age we add 1 point per year of age, then the sex of the patient. If the patient is male 1, we add 10, and the history of cancer will take 30 score. History of heart failure will take 10. History of chronic lung disease we will give 10 also. If heart rate more than or equal to 100%, the score will be 20. Systolic blood pressure below 100 millimeter mercury, score will be 30. Respiratory rate more than or equal to 30 per minute, score will be 20. Temperature below 36 centigrade score is 20. Altered mental status, if the patient is disoriented or there is lethargy or stupor or coma, the score will be 60. Saturation on room air below 90, the score will be 20. The total score below or equal 65, the class 1 will be very low risk. If the total score 66 to 85, class 2, which is low risk. If the score 86 to 105, the class 3, intermediate risk. If the total score is 106 to 125, the class 4, which is high risk. If the total score more than 125, the class 5, which is very high risk. The second table is for simplified pulmonary embolism severity index. There is 3 schedules, include the parameter, score, risk class, then the total points. The parameters include the age, cancer, cardiopulmonary disease, the pulse, systolic blood pressure, autosaturation. The age, if more than 80 years, the score will be 1, which is low risk. The cancer, the score will take 1. Then the cardiopulmonary disease, if there is cardiopulmonary disease, the score will be 1. The pulse rate more than or equal to 100 beat per minute, we will give 1. Systolic blood pressure below 100 millimeter mercury, it will take 1. Auto saturation below 90, with or without saturation, so the score will be 1. Now the risk class, if the total points 0, it will be low risk. If the total points is more than or equal to 1, so it will be high risk. The active cancer diagnosed within the last month or on active treatment, a score of 0 is classified as low risk. The anticoagulation treatment. The anticoagulation treatment will include low molecular weight heparin, as effective as standard unfractionated intravenous heparin, and should be given to patients with intermediate or a high pre-test clinical probability immediately prior to imaging. The unfractionated heparin should be considered in massive pulmonary embolism because of faster onset of action. The first dose bolus prior to commencement of low molecular weight heparin. Renal impairment, estimated glomerular filtration rate. Estimated glomerular filtration rate below 30. Use either unfractionated heparin or low molecular weight heparin with anti-factor 10A monitoring. Use unfractionated heparin if risk of bleeding. Oral anticoagulant. Direct oral anticoagulants are now the mainstay of treatment of pulmonary embolism. Apixaban, dabigatran, edoxaban, and rivaroxaban are all licensed for the treatment of venous thromboembolism. Apixaban and rivaroxaban are preferable as they don't require 5 day 5 days of low molecular weight heparin treatment first. A high dose regimen is tailed off after 7 and 25 days, 21st days, respectively. Again, apixaban and rivaroxaban are preferable as they don't require 5 days of low molecular weight heparin treatment first. A high dose regimen is tailed off after 7 and 21 days, respectively. Direct oral anticoagulants have a lower bleeding risk than warfarin and low molecular weight heparin and are non-inferior in terms of efficacy. The length of anticoagulation, if there is temporary provoking risk factor, the treatment will be 3 months. If first episode of idiopathic pulmonary embolism, we should review anticoagulation at 3 months and we discuss with the patient, including consideration of risk of bleeding and risk of recurrence, and some advocate 6 months treatment or lifelong treatment, in which case this decision should be reviewed annually as the relative risks and benefits of anticoagulation may change. For patients with active cancer, 6 months of low molecular weight heparin before a decision as to whether to continue with vitamin K antagonist long term. Recurrent idiopathic pulmonary embolism, no guidelines exist. Length of treatment depends on individual circumstances, with risk of bleeding balanced with risk of recurrent event and often long-term anticoagulation. Persistent risk factors, lifelong anticoagulants may be recommended. Side effects, the risk of bleeding increases with age and the concurrent illness, higher bleeding rate with concomitant aspirin use and previous GI bleed. Additional treatments for pulmonary embolism include IV fluids, which require to maintain the blood pressure, and sometimes inotropes may be required. High flow oxygen, if there is significant hypoxia and the target saturation is 94 to 98%, significant hypoxia with hemodynamic instability should prompt early intubation and transfer to ICU. Outpatient and ambulatory management, if low risk pulmonary embolism in pulmonary embolism severity index 1 and 2 or simplified pulmonary embolism severity index 0 can be considered for outpatient management as long as there is a robust system in place and no social or other medical reasons requiring admission to hospital. Up to 45, up to 44% of patients may meet criteria or ambulatory management. If right ventricle dilatation is seen on echo or CT, a negative cardiac biomarkers, troponin or BNP, brain natriuretic peptide, can help to reassure that this is not clinically relevant. Advice on when to represent and follow up plans must be provided pre discharge. The thrombolysis. There is emerging evidence to support the use of thrombolysis in certain subgroups of patients with pulmonary embolism. However, this is a controversial area, and the risk over benefit analysis of this treatment must always be carefully considered. High risk pulmonary embolism causing circulatory collapse if systolic blood pressure below 90 millimeter mercury or a pressure drop of 40 millimeter mercury with no other explanation. Current NICE guidance 2012 recommends unfractionated heparin and subsequent systemic thrombolysis. In practice, thrombolysis is usually given to the acutely unwell or pre-arrest patients when the history and physical findings are suggestive of massive pulmonary embolism. In absence of another reasonable explanation, there is rarely time for imaging or investigations in this situation. Intermediate risk pulmonary embolism, those in pulmonary embolism severity index class 3 and 4, if these patients have a high cardiac biomarkers or evidence of right ventricle dysfunction on CT or echo, they should be labeled as intermediate high risk and be considered for thrombolysis or reperfusion therapy. However, the PEITHO study demonstrated no mortality benefit at 7 or 30 days from thrombolysis with a higher bleeding rate. Systolic blood pressure below 110 millimeter mercury and respiratory rate more than 20 beats per minute, active cancer and heart failure were associated with a poorer outcome. No clear guidance exists for this patients group at present, and the senior clinicians must be involved early. Contraindications, non-absolute, rarely a consideration in the life-threatening situation. Risk of major hemorrhage is 3 to 4 times that of heparin, around 13% in large studies, with a higher incidence of bleeding in the elderly. Active bleeding or recent intracerebral bleed are contraindications. Catheter directed thrombolysis and half dose thrombolysis may improve outcomes and reduce bleeding rates, but there is limited current data to support this. Embolectomy, rarely done and only in life threatening massive pulmonary embolism or if thrombolysis is contraindicated. Options include surgical embolectomy, few regional centers only, and mechanical clot fragmentation via right heart catheterization. Inferior vena cava filter placement. There is little evidence to show improved survival or reduction in recurrent pulmonary embolism rate with IVC filters, and changing to low molecular weight heparin may be as effective. They are potentially prothrombotic and should be removed as soon as possible once no longer required. Inferior vena cava filters may be indicated in acute venous thromboembolism in patients with an absolute contraindication to anticoagulation, and patients with recent massive pulmonary embolism who survive, such as a second pulmonary embolism, may be fatal. Recurrent venous thromboembolism despite adequate anticoagulation, and post-pulmonary thromboendarterectomy in pulmonary hypertension. Follow-up. All patients need follow-up, usually 3 months post-diagnosis. Several areas need discussion. The patient is often keen to ensure their clot has resolved. Some centers will use a Q-scan or CTPA, while others go on clinical assessment and symptoms. Length of anticoagulant need to be discussed. Cancer screening and NICE guidance recommends assessment for possibility of underlying cancer in those with unprovoked pulmonary embolism aged more than 40 years with clinical examination, blood tests, chest x-ray, and CT abdomen and pelvis for all and mammogram for women. The echo needs to be repeated in those with an initial high PAP or those with ongoing breathlessness. Consider whether antiphospholipid and hereditary thrombophilia testing is required.